And so this latter part of the afternoon, what everyone is going to be hearing from is really the interpretation and evaluation of those questions by the peer review panel members. And so actually, if we could get the first slide, please, for question number 1. That's not the right one. There we go. There we go. So Dr. Bunton is going to be providing comments with respect to question number 1, and everyone can read this, and since we'll just wait for another minute or two and then begin, but basically what will happen is there's a series of 4 different questions that have appeared, and 1 or more panel members was assigned to answer each question. Yes?
I had a question about, this is Tracy Bunton, about what all to say for this, because I have some comments that are very specific, you know, on this table, these numbers didn't add up. Do we need to, you have those notes, do you want that?
So any editorial type comments, you do not need to speak. But scientific, technical issues with the study, please do.
Okay.
Okay, so we'll go ahead and start. So again, as a preamble, what we're going to be doing is each panel, there's a series of questions that have been posed to the panel. Different individuals are either acting as primary or secondary. Not every question has a secondary, but it is important that after the person who is assigned to the question gives their input, I'll be turning to the rest of the panel to see if there's additional comments. The other thing to please keep in mind and just remember a couple of things, as Dr. Wolf pointed out, we're trying to avoid editorial type comments. Those can be done in a different venue. What we're trying to do is get high-level peer review comments in place. And the other thing is keep in mind your written comments do not replace oral comments. And so if you want it basically something noted in the peer review, it has to be presented in the form of the oral comments. So Dr. Bunton, I'll turn it over to you.
So this was a really comprehensive report for a guideline compliant study with primarily toxicological endpoints. And I thought overall the information was very clearly and objectively presented. I liked especially tables 1 and 2 because you could get a summary pretty quickly of a really complicated data set in table 1 and then the protocol details in table 2. So I thought that probably took a fair amount of thinking on how to get all that information. Although the tables went for pages, I didn't really care. I was happy to see that summary in that format on that table. As far as the other tables, I thought they were straightforward. I spent a lot of time looking at data in tables like that, and it was pretty standard. So I didn't really have any additional comments for that. The other thing, though, that is a more general comment, and it may have been specifically for how I wanted to review the data, was that you presented the information with the BPA continuous, I think it was, and then the estrogen, and then stop dose BPA. And the way in my mind I wanted to look at the data was to see all of the BPA and then estrogen data, or even the estrogen data could have been first, but I didn't, it wasn't the way that I would review the data normally. I kept hitting that estrogen table thinking, where's the rest of the data? So, I mean, unless it could just be me, so unless it is a, you know, was a problem with the other people on the panel, I don't know if I'd mess with it. The other comments I had were editorial, except I did have one additional comment. I should say, too, that I have more, there's more meat to my answers and question 2, so that's coming up. So this one was pretty straightforward. But one thing I don't know if I added preliminarily was that there was a little bit of inconsistency in the subject headers. So just check, and I know this is editorial, but that's okay. page 34 and 35, the two post-weaning survival and survival post-weaning. Just check those headings, because they're saying similar things, but they're not saying it in the same way. So just for consistency in the report. But that's all I had on the tables. I thought it was well done.
Okay, other panel members want to weigh in?
Yeah, I concur. I've looked at a lot of studies like this as well, and I really appreciated those first two tables. It kind of sets the stage, and then I thought the data were well represented and presented. I did, again, it was hard with the estradiol being in the middle of that as well. Again, not a big deal, but, it would be nice to see all the BPA, but I really echo, your sentiments.
So that was Dr. Trinan. So once again, just please introduce yourself just to keep it easier for the, yes?
So Mike Connor, just a minor comment in terms of the presentation of the data. Obviously, and we'll have this discussion later when we're discussing specific results and interpretation, and inevitably you're going to take the weight of evidence approach for some of these things given the multiple opportunities for comparisons and possible spurious significance here and there. So on some of the findings that you saw only in the stop dose group, it'd be useful not to draw conclusions in that section, but cross-reference a section on the continuous dose, say this was or was not observed in the continuous dose, because again, that's going to contribute later to the discussion. For the reviewer, having to go through all the tables and make those correlations yourself was a little more challenging, but again, just a couple of comments within each of those sections, whether or not it was observed in the equivalent group, stop dose versus continuous, for instance, would have been helpful. Because it is a rather dense report, but I mean, well presented, but pretty dense.
Janet Hughes. I actually have a question. I agree that the presentation of data and the results in tables and figures was clear, and that table 1 was helpful, but I did have some comments regarding the presentation of data in the discussion section, but I don't know if that would be appropriate to mention in response to this question or to mention later. Okay. I think the first concern I had was about the interpretation or attributing statistically significant results as biological variability. The purpose of statistical testing in general is to account for probability of observing a particular result when you account for variability. And so we generally would set an alpha level that's an objective criteria for concluding when the probability falls below that the conclusion is no. I, of course, agree that p-values should be interpreted as probabilities, and all statistical tests should be interpreted in light of scientific hypotheses and biologically meaningful differences, but I don't feel comfortable dismissing them as biological variation or blind application of statistical rules, because they are the rules that we have determined a priori that we are going to base our conclusions on in the protocol. And then the other area of concern that I had was the interpretation of the neoplasm findings, and the discussion stated that the comparisons were based on their conclusion. Some of the conclusions in the discussion section stated that they were based on comparisons to the historical controls, and saying the incidence that was observed was marginally higher. And I wasn't clear how saying something was marginally higher was defined, and it seemed like that, in fact, depending on the tests that are used, that the incidence values that were observed, 22 to 24%, would be higher than 11% or 12% in the historical controls. And I also think that the report should be clear when reporting the incidence results, whether it's based on simple incidence or the poly 3 test, because the poly 3 incidence adjusts for the time, the population at risk, as it were, and and so the incidence values are different than the simple incidence values, but then the p-values associated, the report presents simple incidence results, but with p-values that go with the poly 3 testing. I found that confusing. And then the third area I wanted to mention was that the report, is clear that the comparisons were designed to be made within the arm, and the statistical comparisons were made within the arms. Well, I think it's appropriate to qualitatively compare the arms. One thing I just wanted to point out statistically is that the 2-year groups had 46 to 50 pups per arm, and the stop dose and 1-year interim groups had only 19 to 26 pups per arm. And so therefore, when we're comparing statistically across groups, that the power to detect significant differences is different merely due to the sample size. And so that the same difference could be considered statistically significant for the 2-year group and not for the stop dose arm due to the differences in statistical power. And I didn't see any mention of that in the interpretation of the results, that those were quite different sample sizes.
Okay, so I'm going to stop there and try to unpack a couple of the comments. So, and also provide an opportunity for the investigators to respond. So I noted from the written comments from several members of the peer review panel that there was kind of a recurring concern about this issue related to statistical testing and how biological variability was being handled with respect to kind of, I'll say, changing the interpretation of the statistical results. And if I've misinterpreted those comments, other panel members should weigh in. So let's start at that point and maybe toss it back to the NCTR and NTP individuals to see if they want to respond to that concern that a panelist raised, but I'll also say I think that was a concern that other panelists also raised as well.
I guess I'll take a first stab at that. If we'll pay more attention to it in looking at the revision, but we were, based on the fact that we did use, and as you were saying, we could have set a more stringent p-value at starting, and maybe that's what we should have done. But the fact that we had so many different endpoints that we were comparing and had such a liberal p-value, really, that we thought that bringing in a discussion from based on ourselves of the pathology evaluations as to what constituted a real effect and a biologically variable effect was appropriate. So we did put that in, but we could, we certainly could take a second look at the way we discussed that. One thing I wanted to say about could I slip into the last comment and just make a correcting point? That I think I couldn't quite catch. I think you were saying that there was a smaller number for the stop dose arm. I mean, it was in the interim sacrifice. They were all lower doses, and all the EE2s had lower doses. But within the 2-year, within the terminal arm, both the stop dose and continuous had equal sample sizes. So, yeah.
Right, I may have misspoke.
Yeah.
I did understand that, but thanks.
Anybody else?
Yeah, I just wanted to say I'm Paul Felton with NCTR. In a study like this where you have a high chance of lots of false positives, you have to take into consideration lots of other things to try and sort through those. And, so I think it's appropriate to take into consideration historical controls. We don't use that as a test, a statistical test, but it gives a hint as to whether maybe this is a false positive, and then take into consideration other biological considerations.
This is Gonçalo Gamboa. I mean, I would add that it's not unique to this analysis. This is pretty much a standard approach that is taken by the National Toxicology Program to put things into perspective. As my colleagues were rightly saying, I mean, we're dealing with a study that is 7-fold larger than a typical cancer bioassay. And so let's bear in mind all that we have at the table. We're using a p-value of 0.05. We have 4 different statistical approaches being used to analyze the data. So certainly things are going to pop up here and there. And the alternative approach would have been to use much stricter a priori statistical conditions, but then at that stage we might be losing data that could be biologically significant. I think that this is a much better approach to allow more false positive data to pop up in the statistics, and then trying to bring some sense of biological significance as we've done in this exercise. Thank you.
Kim Treinen. To that end, though, I think there was a kind of a lack of a discussion around biological plausibility. Some of the findings that you would see at 1 year that you didn't see at 2 year, like specifically like the uterine stromal polyps, like unless they go to something else, like that's more severe in 2 years, why would you expect them to disappear? So I think that there was actually sometimes a missed opportunity to really talk about some of the lesions and what you might expect at 2 years versus 1 year. And that I didn't see. So if you're going to talk about biological variation, I think there was a miss on some of the findings with respect to biological plausibility.
Yeah, Mike Connor, I was going to discuss this later towards the questions, but it does have to do with the way the arguments are structured. And again, as we talked about, and I mentioned earlier, inevitably you're going to end up with some things that may or may not be false positives, and the question is, how do you approach that in terms of weight of evidence? So I'm less concerned about saying it's biological variability. What is the evidence that it's meaningful? And built into the study are some of those opportunities. If you see something in one dose group and the stop dose group, but you don't see it with continuous dosing for 2 years, that might raise questions about the plausibility. And if you take the one example that's been brought up several times here, which is the adenocarcinomas at the 2.5 microgram per kilogram in the stop dose group, the question is that biologically relevant? So and the way we often construct these arguments is, and again, this is great because you have the other dose group, which gives you some perspective. Did you see it in the other dose group that was dosed continuously? You also have the question about, in this particular case, was there a correlation with pre-neoplastic findings in the same dose group? That would make that more likely to be a biological effect. And the reason you look at historical controls is not to make things go away, but again, to kind of place life in perspective, because although these studies feel really big, but for tumor incidences that are low, they're actually statistically pretty small, to be fair. And so it's very difficult sometimes to see effects, or sometimes you get effects that may not be real. So again, this is the only reason, it's not to make things go away, but to place this in perspective, again, as part of the weight of evidence argument. And then again, there's the question about the literature, and some of the outside comments have pointed that there may not be a linear dose response for these kinds of things. So seeing things at a low dose might actually be real biological events. And so bringing all that together in the weight of evidence gives you an opportunity to say that for any particular finding, the weight of evidence is for or against this being a treatment-related effect. And I think so as we go through each of those effects that were in the discussion, so again, this isn't to argue that the 2.5 adenocarcinomas is real or not, but the way you construct the arguments for a weight of evidence should kind of include all those points. And then the other point to bring up, and again, there was one slide that was nice by one of the outside commenters this morning, looking at all the effects that we're seeing. And again, not the same organ system and so forth, but you start to see a lot of things showing up at that 2.5 to 25 microgram per kilogram dose group. And again, as part of the overall weight of evidence, was there an effect of BPA at these low dose levels that heightens your sensitivity that there might be a biological effect? Again, I'm not drawing a conclusion there was or there wasn't, but these are the kinds of ways to construct the arguments in this instance so that the writer can then reach that conclusion. Is there biological plausibility? That's all.
Thomas Rosol. Sort of what I was looking for, since there were so many statistical analyses, I really wanted to see a very clear tabulation of which changes are felt to be compound mediated. And so that, you know, the interpretation was that the statistical findings were compound mediated or not compound mediated. And if the conclusion was that they were compound mediated, then I wanted to see some discussion about relevance, biological relevance, because I think the discussion varies depending on which of those. And then if there are some areas where, you know, some areas that are sensitive, like the tumor findings where you don't think it's a compound mediated effect, I think you should discuss why, specifically why you don't think it's a compound mediated effect, using all the factors we use from pathophysiology. So it's really hard to read this document and get that succinct information. A couple times in the summaries, I found statements like, well, we're really quite unsure about something. You know, not everything is going to be clear, and I thought that was good that you're bringing that up. But it wasn't well explained. You just sort of left me hanging a little bit. So on the areas where you can be clear that you think there is a compound mediated effect, I think that should be easily tabulated and then lead to discussion. Going directly to biologic significance without making it clear which of the statistical findings you consider to be compound mediated, I think sort of makes it a little harder to understand.
I don't want to drag Mike Connor, I don't want to drag it on too much, but one of the challenges, and we face this all the time in the pharmaceutical world, is you look at a range of effects, and is it treatment related, clearly not treatment related, or of uncertain relationship to treatment, which is the category you try to use the least, but because then it's sometimes considered equivocal and should be considered treatment related anyway. But at the end of the day, you have a number of findings here that probably would end up in that category of uncertain relationship to treatment. But as Tom pointed out, it's not just saying that, but providing the weight of evidence for and against, and why you believe it's too hard to call, or where you fall on the line there. So that's kind of a continuation of my previous comments.
Sure.
I have one more comment. I also, what I'd like to see added is I'd like to see a little more discussion on the expectations for exposure for both BPA and for estrogen. I think that would be helpful for the reader to understand what you're expecting in terms of blood levels and what your previous experiments, sort of you would predict in the 2-year study. I think that would be helpful.
Anyone want to respond? Okay, so going back to unpacking the comments, so another issue is related to reporting of incidences. That seems to be probably more straightforward, I would think. And then I'm not sure that I heard a complete response yet, or heard enough from the panel with respect to concerns about statistical comparisons between the different arms of the study. And so I just want to bring that up again as one of the third points, just if there are any concerns raised by the panel that have not been captured already, or if there's any additional responses that NTP or NCTR would like to make regarding that issue. Okay.
This is Nigel. Just a question about the reporting incidences. You're referring specifically to the discussion area where, even though the poly3 and simple incidences is all in the tables, in the narrative sections where calling out certain incidences, we use in the simple and then just the p-value, which is driven from the poly3 incidence. That's just to clarify that one.
Yes.
Okay.
Yes,
yeah.
in the discussion, it was like 22 versus.
Yeah. Because all the
p-value, but it's really 33 versus 9 or something.
Because the poly3 incidences are in all the tables. I'm just want to make sure.
In the tables, yes. In the tables, it was clear. But
okay.
In the
narrative.
The narrative,
okay.
It mixed the p-value with the simple incident.
All right.
So let me to clarify for myself as I probably be one of the people at least writing the revision of this report. But in terms of the discussion, now I'll say in the first draft of this report, we did do, in the results section, we did discuss stop dose versus the continue, and we got that out of there and put it more in the discussion where I think it more appropriately belongs. But you feel that in its current form, there's still too much discussion of that, of comparisons between continuous stop or
Well, maybe I need a little clarification. So is the concern the qualitative discussion between those two groups, or is it the concern is more quantitative? And so I thought I heard the comment that the concern was maybe doing statistical comparisons between the arms in a more quantitative way.
Yeah.
So, this is Luisa Camacho. So we did not compare statistically the stop arm with the continuous arm. We just did a qualitative comparison at the discussion.
Okay.
My comment, this is Janet Tews, my comment was in regard to, the discussion, the qualitative comparison, and I just wanted to point out the potential differences in power. So you could have the exact same effect size and have it be significant, the same, difference between two groups, and it could be significant with 50 pups and non-significant with 20. And so I just think it's important when we make the comparisons that it's not just whether it was statistically significant or not, but how similar the estimates were.
So this is Luisa Camacho from NCTR. So just to clarify again, so the stop arm and the continuous arm, they had always similar sample sizes within each sacrifice time. So in the interim sacrifice, they had between 19 and 22 pups per group, per sex. In the terminal arm, they had between 46 and 50, regardless if it was a stop dose or a continuous dose BPA.
So are you saying you didn't make any comparisons across sample sizes?
You mean between the 1 year and the 2 year? That would be...
Yeah, I think where I'm seeing where there would be a difference in sample size, it would be between the 1 year interim data versus the 2 year, and if we're comparing between the BPA and the ethinyl estradiol, not so much between the different arms, because I appreciate the comment that in those situations we reduced the sample size for the ethinyl estradiol because we had a stronger sense that the power to detect a response was going to be higher because we knew it was going to be a more robust response. So the power was probably more similar, even though it was a smaller sample size. We were expecting the effect size to be higher because it was the ethinyl estradiol. But maybe that was, I'm not a statistician, so I think I may be confusing that. But yeah, those are the situations where we had differences in absolute power based on the sample size, but not so much between the continuous and stop, but the time-dependent transitions in the ethinyl estradiol.
Okay. So I'm going to declare victory on that point, I think, just because I'm going to declare victory. So let's move on to question 2. And so Dr. Connor is going to take the lead on question 2, and Dr. Bunton is going to provide some additional comments. And then again, the rest of the panel can weigh in as well. Okay,
so again, this is a comment on study design and conduct used in these studies. And in all cases, when you conduct a study, the question is, was it designed for what? And although it's kind of in the preamble, when you look over the intent of this study and the way this study was designed, it really seems to be designed to answer 3 to 4 questions, which is to establish the effects of exposure to BPA in both male and female rats, starting in utero and going through 1 or 2 years of age, and establish whether or not effects of rats exposed in utero in the perinatal period would have long-term effects. To establish whether BPA has effects on age-related findings. Again, that's designed because you have the 1 and 2 year necropsies. And also to establish that the rat model used was sufficiently sensitive to the estrogenic effects of standard compound, the positive control, that it would be considered appropriate to do these studies. If you look at it from those 4 questions, it's always dangerous, although, to write your purpose of your study after it's done, because then, of course, it met the goals. But nonetheless, those seem to be the questions that were being posed. And if you judge it against those questions, I would say that, yes, it seemed to be adequately designed. Some of the strengths of the design are some of the things that others of us sometimes feel problematic, the stop dose group and so forth. But those actually allow us to do those qualitative, not statistical, but qualitative comparisons as we're trying to understand the weight of evidence approach for some of the findings that may or may not have turned up in this study. So I find that actually a strength of the study. I think some of the other strengths in design and conduct is there was a significant effort to try to get as BPA free as possible, but that went with continuous monitoring, and there were some challenges there, but I think the approach there was appropriate. Years ago, I was involved in studies using trace elements, and that turned out to have much of the same challenges, trying to find the diet and the environment in which you could actually do those studies effectively. So it was a significant challenge, but I think the approach that the NTP and NCTR used was appropriate to try to address that, despite the fact that you can't really get a totally BPA clean environment. That was again, a strength of it was you at least documented what those potential exposures were. And so I would say that kind of summarizes my comments. The question is, was a study design and conduct for the purposes of this study, and those 4 purposes that seem to stand out, I'd say, yes, it was adequate for that. You'd always like larger number of animals when you have this many comparisons to try to reduce the frequency of false positives. But from a physical perspective, the number of animals per group is about what could be managed. So with that limitation, I would say it's adequate for the purpose.
Okay, Dr. Button.
So I had actually the same impression, maybe overall, in that I didn't know what the question was. What is the question for the study that you're trying to answer? And so, I mean, even if it could have been articulated in the beginning, because now as I've gone through it, and as, Dr. Connors then mentioned, he kind of figured it out, I think, as he went along, and then also listening to the presentation. But I didn't understand why you did the study this way. And that may have come from, I'm sure it did, a lot of discussion with the various agencies. Because I felt almost like you could have done a straight up developmental process as if BPA was a drug and gotten a lot of answers more cleanly. That is, because you've got your general tox, you look at what happened there, you've got your chronic general, you've got your 3 stages of reprotox, in which you could have looked at it that way, and then carcinogenesis, and you almost have covered everything. And then you have a huge database of information or background information to go with. So what's unique to this process is that you are then going straight through from exposure during in utero through to carcinogenesis, so the full life. And if that was the goal, then that should be stated. And I think that's what we've kind of come around to. Because the trouble, and even then, I think the trouble is that might work better with a compound that doesn't have a hormonal influence. Because what you're doing through a lifetime is you're going through gestation, you're going through the perinatal period, through adulthood, through senescence. And all of the hormonal dynamics are going to be different at those stages, and then you're superimposing BPA at different concentrations, such that you could potentially see an effect at a lower dose. This is my own thinking about that, and I have to go through this in my job too. But you could potentially have it at a lower dose. You've got the normal cycling of a female rat, for example, trying to bust through that superimposition, whereas at a high dose, it's just crushed. So you're able to see more clearly, this is what is happening when you have this level. But at a lower level with a hormonally active substance impacting the normal cycling, I think it gets complicated. So that's where I think probably I was glad to hear that, and I'm glad that there is like the academic arm or the grantees are going to be looking at different aspects as well. But I'm not sure how it will, we'll see, I guess, how it will tie into the data with this study. So I think that was kind of my overall impression in doing this. The other big thing that I wondered about was if you have any concerns about not having any exposure data, plasma exposure data, and that's come up, I think, with various reviewers or else in the public comments. And I know that would increase, I mean, you can't, it's hard to imagine adding more animals on top of this. But you could get to a point where with this vehicle and, these doses, you figure out when steady state is, and then I don't know if you kind of consider that, because there's things that can happen. And even you have concentrations in some of the literature, but you don't have your steady state data. So there are things that can happen to exposures with time. And I wondered if you had concerns about that. I mentioned earlier, just to add some justification about why you took the interim groups, I think would be good to add to the report.
Okay, well, we'll stop there, and I'll kind of toss it back to our colleagues at NCTR and NTP to see if they want to respond to the first two reviewer comments.
So I guess, stating the purpose of the study more clearly in the beginning should be done. I agree. Redesigning the study, we can't do. I mean, we've got.
I understand
but and we could have considered that. And the third point, the exposure data, we felt. I mean, we've really got a pretty extensive pharmacokinetic data on this strain of rat at various ages that Dr. Dorgey's lab has published from this strain of rat in terms of, we do the gavage dosing. We know what the pharmacokinetics are from that. So I think we can make a pretty good estimate of what those animals were exposed to over that dose range at the various stages of their life. And I'll say that, as Dr. Russell said earlier, I think we probably could have done a better job in the report of describing that and explaining what we did, and we'll do that. But so.
If I may. Just because I'm not sure it's clear, we never mentioned this specifically, but the 90-day study that we keep referring to for the internal dosimetry, we used exactly the same dosing procedures as we used in the chronic study. So the only difference was that, so the range of doses was different, and then we stopped at 90 days. But it was the same vehicle used, same formulations, still the oral gavage at the same dose level, volume per kilo of body weight. So everything should translate, in general, the internal dosimetry data from the 90 days should be applicable for the 2-year study.
One thing to remember is this, and I try to put it in the opening talk about the whole program, is this study, while we are reviewing it in isolation, it doesn't sit in isolation. It's part of this continuum of information, not only from the earlier 90-day study, all the kinetic work that was actually both in rats and mice and non-human primates, adult and perinatal, to which a full pharmacokinetic model that is trans-species has been developed. Add that to the fact that we've got all the grantee information as well as this information. There's lots that we could have tried to put into this single report, but we're actually beyond the scope of this report. And what we're trying to do today is really deal with this report in isolation, even though it doesn't sit in isolation, which is kind of a real challenge, because that goes to the comments earlier on about how much biological interpretation we put on a lot of the statistically significant effects. One of the hopes is we will be looking not only at this information, but also the kinetic data, the grantee data on siblings from the same groups, to see whether that gives us a more robust interpretation of effects. And so to a certain extent, there's a bit of a challenge to kind of how far do you go but not go too far that you've already made your mind up on what you think is happening in this core study where we're going to have additional information that might be able to be brought to bear on it that we can't bring in at this point. So I just kind of wanted to reflect on that. But Tracy, you've raised a lot of questions about what we could have done here, but some of that is outside of the bounds of this particular report. And it will be brought together at some point later. But it won't be here.
But overall, the specific objective, the hypothesis for this effort was that there was going to be, or you could say there's not, a generational effect, or there is a generational effect, and that is what you wanted to, through the lifetime. Is that, I mean, I just wanted to hear somebody articulate the question.
I think Dr. Bucher's going to address that one from the very inception.
Oh, okay.
Maybe. Is it on? Okay. No, I don't think it's on. But so I guess really what we're trying to do with here is to explore the bounds of the power of the more or less standard guideline studies to pick up endocrine active agents that might be working through dose response scenarios that we don't really fully understand. So the challenge, of course, is to generate a study that is sensitive enough to pick up things that you think should be picked up, and yet not over-design it to the point where it's not realistic from the standpoint of answering the overall question, which is how can we compare all of this academic information that's using specific models and specific technologies and coming up with certain answers that seem to differ from those that you get when you do a standard study. So it's a balancing act, and I think that this was always a challenge in putting this together, even especially since the academic consortium were interested in, in designing a study that was as powerful as possible. So we're walking sort of a tightrope in the design. I hope that helps.
Other comments from the panel? So I have a question for the panelists regarding the dose.
Well, I just had.
Go ahead.
I just had one other question / comment. And as we've talked about, and I mentioned several times, this weight of evidence approach to understanding biological meaningfulness of certain results. There was not denying the results are there, but what are they? In the context of the multiple comparisons, what's the biological relevance? Obviously, the data that are being generated in the academic labs may shed some light on that. So it's kind of a procedural question. This, as a core study, could be wrapped up and finalized. However, based on the weight of evidence for understanding biological meaningfulness, is it likely to be revised once all the other data are in, when you start looking at some of the other hormonal changes and endpoints that are going to be coming in from the outside world eventually? Because again, if I were to make the arguments based on what we see today about biological relevance, you might dismiss or accept something which turns out later you might reach a different conclusion. So I was wondering, how static is this report when you're done with this exercise?
That's a very good question. I can talk about historically, we do not tend to go back and revise NT reports. They're usually based on a contemporaneous evaluation of the data at that time of what's available. But I've often had situations where we've gone back and integrated different data streams into an evaluation. I'm thinking report on carcinogens, Office of Health Assessment Translation, integration of different information. And that builds on what has been previously said in other reports, but we don't go back and change those if the conclusion has been upped or down. It's that we basically move forward with that. But it would be, the way that I would see this coming. That's why I pointed out that the integration report and that step and that review will be is a subsequent step to this, and will take in multiple areas. So to that extent, will it supersede it? this is the conclusion on this information at this point in time, in the absence of having that information, and we'll have more information later on that may change those conclusions.
So that would be handled in the integration report that comes
Yeah.
later. Okay, that's fine. I was just wondering procedurally, because.
Yeah, that is the whole, that's why I pointed out that the three key elements of this particular consortium is the core study, which we're reviewing today, which is how we would look at a guideline study in the absence of having, as John pointed out, these additional endpoints that we wouldn't normally be looking at. What would we conclude? When we bring in these other endpoints, would we have concluded differently? That's what that integration report would be about.
Just to kind of follow up, I can say quickly, though, I know you want to talk about stop dose, and I do have that note. And I think that is a value. I thought that was interesting to think, okay, with the stop dose, if you stop dosing, if you stop the exposure, then do you see different changes after compared to the continuous dosing, or the same changes? So that was a unique aspect, I thought, to this study design. Just to add on, so I won't forget it, what somebody else brought up, I think there's a lot of material in here that could be of interest, and I don't know how many ways you need to look at this, because I know you've done a lot. I completely acknowledge what you've done, but there are, especially in the non-neoplastic changes, and that you might try to use in the context of explaining, and I think Dr. Connor came up with that, because I did that myself, and looking at, okay, we've got a tumor incidence at 2.5 micrograms of BPA. What else is happening in this group that correlates with that change? So I look for things that could be affecting the hypothalamic pituitary gonadal axis. So are there changes in the ovary? Are there cystic follicles? Are there, is there hyperplasia? Is there something, the decrease in the CLs? If you just compare it to the estrogen group, things that are known to be caused by estrogen or an effect on that axis. And I didn't really see it. I wasn't convinced. Even the atypical, what is it, foci in the mammary gland, they were in the continuous group, I think, I'm forgetting now, but not in the stop group and not in the estrogen group. So there are different comparisons that can make or break an argument one way or the other, because I did specifically look for that, and I could not find other factors in that group, in the other organs that should have been in those animals. Why wouldn't they be impacted if the mammary gland is being impacted in a meaningful way, in a biologically significant way? So that's the type of thing, and there are a number of things like that that might then make more sense when you get the grantee information in that could potentially be lost. But it is in here if somebody wanted to go back and do those correlations.
Kim Trinan. I just actually wanted to talk about the stop dose group. I wasn't as enamored with it as other people were. I think it made it difficult to interpret because, again, the exposure concerns me, or not knowing the exposure, or just realizing that the exposure really precipitously drops over time. So I don't know how different a group is that stops dosing at day 80 versus one that doses for 2 years when I have less than what picogram or picomolar or whatever after day 80. So I think there's, with respect to exposure and long-term exposure versus short-term, I don't even know if it's all that different since, we have this exposure decrement. And then I'm not sure a lot was done with that data with respect to like how it was compared to some of the longer-term dosing. There wasn't a lot done with that. There was descriptive discussion of everything was very descriptive, but it wasn't really integrated to me. And I don't know what we really did with the stop dose group and how it really helped with interpretation with the rest of the data. That wasn't obvious to me.
So while we're talking about the stop group, several commenters from the public raised concerns about there not being a stop group for the positive control. And I just want to find, kind of touch base with the panel to see within the context of the study and the purpose of that control group, is that a concern or not? And just want to spend a second or two working that issue.
Yeah, Kim, trying it again. Yeah, I was going to talk about that when I talked about the estradiol group in comparison to estradiol. Again, hindsight's always 20/20. But when you really look at one of the major findings that people may be concerned about, the non-monotonic, effect on adenocarcinomas, and you don't have a positive control, it's a concern. Or it's not. I mean, if you had your choice and you wouldn't have had restrictions, it would have been a group that would have been added.
Yeah, we were already pushing the limits on and the inclusion of the ethanol-estradiol reference was really to kind of again to bridge from the past studies that had been done with the endocrine disruptor to be more contemporaneous, and to have that there as a reference. They weren't necessarily classed to be as positive controls for some, but yeah, it was logistics was really starting to hit, because you're now balancing. Is it more important to have pathogenesis in the 1 year and other interim time points? Is it more important to have an extended dose, a higher, because initially some of the earlier designs were thinking, maybe we're only going to do 3 or 4 doses. But then making sure we had the full range and all of those things kind of came into consideration during finalization.
One unfortunate aspect, though, is that there was another dose group included, the 0.05 estradiol group, which really wasn't, I think, again, in hindsight, all that informative. Yeah. It was based on, that had never been tested in this, paradigm before, and it really didn't do much. So you could have actually, again, this is all hindsight, but you could have taken those animals and done a stop dose and really not had 2 levels of estradiol. I also, again, based on, lack of exposure data, it's hard to even compare what to say about estradiol. Again, I'm answering my question now, if I can, to a certain extent, what to say about estradiol compared to BPA. And you'd have to bring in potency arguments. I mean, there's a lot more than just specifically, plasma exposure, but, it makes it hard when you have a positive control, and I don't really know even how to relate that, back to the substance. But you at least can tell if your model is working. You can understand if you do see, expected estrogenic effects, but again, that 0.05 group wasn't really very informative.
I see Barry nodding his head because we argued, the whole team and the consortium argued over that quite a bit. Because the 5 had been somewhat too high in the 90-day earlier study.
Yeah, we could have, this was a large study that we described today, but in parallel for that 1 year was an equally large study going on to provide the animals to the academic labs. So we really were in a hard place, and we had to make some tough choices at the beginning, and maybe we didn't make the ones we would have made having had, but that's.
So I'll throw in my 2 cents about the perspective. So you always run the risk of getting scientists wanting to redo an experiment that can't be redone. But maybe what I would encourage the report authors to do instead is to just consider some of these comments with respect to how you present the strengths and limitations of, say, that positive control group, and whether or not having a stop group for the estradiol group limits your ability to, say, interpret certain data. Because obviously we're not going to go back and add pharmacokinetic data. You're not going to add different things. But again, just trying to make it explicit to the reader of the report kind of how this study gets bounded in strengths and limitations. That's all.
Yeah, and just to address the comment about the kinetics, particularly with BPA, we really know the kinetics of BPA. And so one thing we do know in this model is that when we do stop that exposure, we've stopped that exposure. So this was very clearly targeted at understanding within that short window what would be the impact on, on the animals. So I don't think the kinetics really related much to the BPA question, probably more for the ethanol estradiol if we would have stopped that.
Got a couple more comments. So Dr. Rosal wanted to make a comment, Dr. Connor will, and then I'm actually going to hope that we can wrap up parts of question 2 so we can move on to question 3. But Tom, you're next, and then Mike, you'll be next after that.
Yeah, in terms of the stopgap experiment with the estradiol, I mean, of course, in an ideal world, we would have had that. I know we didn't, but the document states that it wasn't done for resource issues, and I can appreciate that too. But however, we have all the data now, and I actually don't think it was very as necessary as it might have been. So I think that could be discussed in light that there's really very few findings in the stopgap group, and the only one I was particularly interested in was the cystic follicles that were seen in the high-dose BPA stopgap. And that would be one where it would be nice to see if estrogen did that, because that was one of the few findings I thought could be plausible, might be interesting, and the statistical findings were supportive. So take that away, all the other findings didn't raise the concern. So I didn't, at the end of reading the study, I wasn't concerned that it wasn't there, except for that particular diagnosis.
Yeah, Mike Connor, again, the only, it's always easy, as you point out, to redesign the study after the fact, but when I looked at the study design, I interpreted the ethinyl estradiol arm merely to demonstrate sensitivity of the model, not to answer specific questions within any of the arms. So that's why I looked at it, and I was guessing that's the way it was designed. But again, of course, it'd be great to have it for the stop. But as far as the stop dose group, it's kind of like a pre-postnatal study without the breeding phase. So it's really asking a question: did this perinatal exposure have an impact on the long term on the animals? And that's the way I interpreted that arm, independent of what was going on with the long term, the continuous dosing arm. It was kind of like 3 studies into one. One positive control, one with the continuous dosing with 1 and 2 year interim necropsies, and then this partial pre-postnatal study, which is the one that actually kind of gave us some interesting findings to deal with, oddly enough. But when you have to design the study, you don't have those findings in hand to know this. And I recognize there are some limitations because of study design, but there's limitations because of practically executing the study. So I kind of accepted that as limitation on interpretation.
Go ahead.
So I just wanted to, I hope this one's on. Is that on? Mentioned that at the time the study was designed, the discussion over the appropriateness of this positive control was an intense discussion, obviously, because there was a lot of evidence at that time that BPA was working through non-estrogen, at least not as a traditional estrogen pathway, and through other potential hormonally sensitive pathways. So you're right. I think in hindsight, and I think that everybody who was involved in this study would agree that the estradiol or the ethinyl estradiol arm was built in as a measure of sensitivity of the model, not as a mimic that one would expect to see the identical things in a stop study with EE2 versus BPA.
Oh, and if that's the case, then again, that should probably be brought into the report as well, because it's not exactly clear. I mean, one starts to think about it being, again, a mimic, and as well as with the model. So I think that might be benefit from discussion.
Okay, let's move on to question 3. And so our lead for question 3 is Dr. Tooze.
So yes, I found that the statistical approaches in this study had been appropriately applied. For most endpoints, there was a comparison of treatment groups. The comparison of treatment groups to control was adjusted using Dunnett's test, and the statistical analyses appeared to be reasonable approaches for the data structure. The statistical comparisons were primarily conducted stratified by sex, dosing arm, whether it was BPA or estrogen, and the time of sacrifice. Due to the presence of the non-monotonic trends or possibilities of those trends, the relative treatment effects method was used. This is a rank-based non-parametric method developed for factorial designs, and it can be used to test for treatment and dose effects and their interaction and therefore can be used for severity as it was in this study. The RTE can be interpreted as the probability of obtaining a smaller value from the full data set than a randomly chosen value from the group. And therefore, you can use a Wald type statistic or Nova type statistic to test the hypothesis of a group effect. And so I found this to be an appropriate test for these types of data, and that it was useful for the potential presence of non-monotonic trend.
So in this particular case, I'll turn to the rest of the panel to see if anyone wants to add to that discussion. And then I'll turn to NCTR and NTP to see if there's any comments that you want to make in response.
The only comment that I would make is if there was anybody had any discussion about the lack of adjustments for the pathology analysis.
I guess my only comment might be to just justify why there were not why those were not adjusted. I guess I thought perhaps it was because of some of the low incidence, but I guess it would be helpful to directly address that in the report.
Do you ever adjust for any studies done at NTP for the pathology data?
You mean for multiple comparisons?
Yes.
That's I could probably pull in, but I'll channel our statistician. We don't, but the weight of evidence approach, people have done assessments on the weight of evidence approach, and in general that controls our false positive rate to the P.05 level. So in essence, we kind of deal with it using this, looking at biological significance, looking at pathogenesis, plausibility, dose gradient, a lot of these other factors that were alluded to earlier on in terms of looking at just the raw statistically significant endpoints. We kind of control for that by actually using the weight of evidence approach. That's kind of a subjective answer, but that's kind of, I think that's what the statisticians here at NTP would have said.
If I can, I mean, without wanting to beat on a dead horse, but I would like to remind you again that we're dealing with a study that is 7-fold larger than the studies that where we normally do not correct for multiple comparisons. So the critical token with which we need to evaluate the data here needs to be even higher from a biological plausibility standpoint.
Okay, if we can move on to question 4.
Yeah, question 4. This is Kim Treinen, is commenting on whether about the use of estradiol as a reference compound. I thought the data was very clearly presented. It was very factual and always addressed what was seen in the concurrent estradiol arm, so I had no issues with how it was presented. And I've expressed my other 2 concerns, which is one, not having it in the stop dose group, and as well as the low dose not being, incredibly informative. But besides that, I thought it did demonstrate that the model was effective in showing estrogen-related effects.
Okay.
Yeah, I don't have much to add. I think we discussed this quite a bit. I have 2 quick comments. One, I'm intrigued by the fact that estrogen alone was so carcinogenic, even though probably the exposure level was rather temporary. So I think that was, I learned from that, and I think that was an interesting observation from that part of the study. And I think the 1-year time point is a really important, to compare the estrogen to the BPA, at least for potential BPA estrogenic effects. I think the 1-year time point is really critical and should be emphasized in the discussion. Those were all my comments. Thank you.
comments from the?
So did you feel like it wasn't adequately assessed, that comparison at the 1 year? We should bolster that a little more then in the discussion. Was that what you mean?
Just didn't seem front and center to me.
Okay, so I saw Mary twitch for a second, but I don't think you were, I think she wasn't twitching, so I'm sensitive to people twitching around me. So we're a couple of minutes ahead. I am almost in fear of suggesting a 5-minute break and we'll reconvene at 2 o'clock. That means no one gets to go on a tour. Okay, so we'll be back at 2 o'clock.
Outdoor mass, no,
Okay, so
no evacuation.
So the next couple of hours, or the major activity that the panel needs to work on next, is to try to, I'll say vote, but I always hate the word vote, but to try to agree on the draft scientific interpretations that the NTP and NCTR have come up with respect to the core study. So the 7 draft scientific interpretations are present on the board here, and the process actually to me is a little bit confusing when it's all said and done. So here's Dave's interpretation of the process. I'm going to ask the panel members if there's anyone who feels like they would want to make a motion to adopt all 7 of the draft scientific interpretations. So by doing that motion, you're basically saying, yep, we're good, all 7. That motion could get seconded by a second person who is also in full agreement with all 7 draft scientific interpretations. And then we vote, okay? And if the vote, the ayes and nays get counted, so there's a lot of rigmarole that will go on, okay? And if at the end, we don't come to consensus, in essence, or have a positive vote to adopt them, we'll then back the truck up again to where we are right now and go through each scientific interpretation one at a time to try to actually discuss them. I anticipate that we're going to be discussing all 7 of these interpretations based upon the peer review comments that were provided in draft form. But having said that, I'll ask whether or not anyone on the panel wants to forward a motion to accept all 7, and if anyone is willing to second it, because otherwise what you'll see here is if there is no motion or second, or if we vote no, then what we'll do is we'll go back to each interpretation separately. There's a few caveats. So NTP has asked us not to rewrite the interpretation. So our job is not to wordsmith the interpretations. Our job is not to say, here's how the interpretation should have been made. Instead, we can give them information about what direction we think the interpretation should go, but we're not being asked to rewrite the interpretation. So no wordsmithing's really needed, but we are trying to give guidance as far as why we might be concerned to either accept or not accept one of the scientific interpretations. So I'll throw the floor open to the panel to ask if there's a motion to adopt all 7, and then we'll go from there.
To be consistent with what I wrote 2 weeks ago, I would make that motion that we accept all 7. Sorry, it's Mike Connor.
So that was a motion made by Dr. Connor. Anyone want to second that motion? And you don't have to be held beholden to what you wrote days or weeks ago. Okay, I've heard no motion for seconding. It's like the world's longest preamble to get to where you think you're going to end up. So what we're now going to do is go one by one through the draft scientific interpretations. Well, isn't that wonderful that we anticipated that that was going to occur? And so the first one is presented here on the board. And so what I would like to do is ask for the panel to basically, I mean, I'm not sure that I want to go through like a motion second with every single one, to be honest. But what I think I'll do is instead I'll ask to kind of straw vote it as far as how many individuals would adopt it. And then if there are people that are not comfortable adopting it, let's hear the rationale behind it. So how many individuals on the panel right now, and I don't vote unless there's a tie, and with 5 people, I don't have to vote. That's great. So how many, what?
Mary's got a frown.
Oh, Mary's got a frown.
I always get worried when Mary has a frown.
So it's certainly fine to have a straw vote to kind of get a sense.
That's
but
what
I
I'm
know-
trying to do.
Okay, but to move to the vote where we get yeses and nos for the record,
Correct.
we will need to have a
Correct.
motion.
We're doing,
Okay.
right now what we're doing is a straw vote just to see where we're at. Thumbs up, thumbs down. If all the thumbs are up, then I'll ask someone to make a motion to adopt and we'll move forward with that. But I'm just trying to gauge the amount of discussion that we might be having with each draft scientific interpretation. So straw vote, thumbs up, thumbs down. You're not held formally to this. How many of the panel members would adopt this interpretation as written by NTP? So all those in favor, raise your hand because it's too hard to see thumbs. So 1. So in our straw vote process, there's a concern. So what I'll do is I'll ask the panel, individual panel members who are concerned, let's have a few minutes discussion about what the concerns might be. And then that way, at least that gets raised for the NTP and NCTR. And eventually we'll come back to a formal vote at the end of raising those concerns. So if anyone wants to start with a discussion of concerns. And Mary, are you frowning about that process? Or are you good? Okay. So anyone from the panel want to provide a rationale for why they were not enthusiastic or didn't vote yes?
This is Tracy Bunton. So it's maybe more in wording because I agree that it did produce what looked like minimal effects and there were varying doses, but I can't go with only distinguishable statistically from background because it depends on the status of the animal. You know, there were some changes that were lower at the interim and then higher later, and I think there are effects that are in here that are not going to be picked up statistically. So that's where I have a problem, just in the language of it.
I had an issue with only, but I had a slightly different bent on it. I guess when I read only, it means that there's no biological plausibility, and I'm on the fence about that. You know, I think there's no effect if you believe that there's no monotonic dose responses don't happen. And I don't have a horse in this race with respect to even knowledge one way or the other that they do or don't exist. But I'm not sure it's as definitive as that in the report to say only. That is only statistical.
I had a concern with the word only as well, and also with the word minimal. While it did appear that some of the effects were small, I guess as someone who is not a content area expert, I wasn't convinced that the report clearly described what would be a minimal effect versus not a minimal effect in terms of biological significance. And this, I guess that's my same comment related to only statistically. Certainly there were effects that were distinguishable statistically. I was sort of interpreting only, saying that they weren't biologically meaningful, and I didn't get that out of the report.
Yeah, I can't vote for this right now just because I can't accept the language. I don't think it really tells me what I want to hear. I sort of agree with it in spirit. But what I would need to see is, to me, I don't know if there's any effects below 25,000. So to me, all the changes I saw below 25,000 are equivocal. So when they say that produced minimal effects, I interpret that to someone saying there were effects. They were just small. Okay, I'm not even willing to go that far. I think there's some equivocal findings below 25,000, and that's it. And I was more convinced with one or two findings at 25,000, and that's how I would state it personally. But I don't think this is an accurate statement from my perspective.
Okay. Tom?
I was just going to explain why I voted yes. It was in, as Dr. Russell said, it was in the spirit of the language was in the right direction. Since we couldn't wordsmith it, I'd be willing to concede to say no, because I think item B, or 2 on your list here, gives the additional explanation that would provide clarity. And so if you vote yes on 2, number 1 could go away and wouldn't have a big impact on the overall interpretation of the study. But I only voted for number 1 as written because it was an approximation of the truth. You know, without, but I understand, I had reservations about the word only and so forth, but not to the point where I would vote no. Anyway, that's where I was.
Okay. So I'll provide, I'm not seeing a lot of eagerness for additional comments on the part of the panel. I will provide an opportunity for NTP and NCTR to respond. Before we do that, though, I do want a procedural note, so I'll go back to Mary again. My intention was at the end of that response to turn back to the panel to see if they want to make some additional comments. And then I was going to just put it to a vote without a motion and a second. Is that okay? Or do we need a formal motion? Like, how bad do I have to do Robert's rules, or can I do Dorman's rules of order?
Our process is usually to have to do the NTP process, which is a motion, a first and a second to not accept or to accept.
So there would, so the motion could be to not accept.
Absolutely.
Okay. As opposed to a motion to accept and have everyone vote no.
Yeah, I mean,
Okay, so
theoretically, and then we would just clarify,
Sure.
again, that the comments we heard were the reasons for the no.
So for the panel, just keep that in mind, because I'll eventually turn to for motion in a second. But so for NCTR, NTP, any response you want to make?
Not really a response, but a question as to how this will be brought to us. I mean, if it's we have to we'll be amending the statements of interpretation based on the comments that we receive. Is that?
You will receive these as advisory to you, and NCTR, NTP would potentially make revisions to what you think the scientific interpretations are based on how you view the advice you get from the panel.
Okay, and then I address how, I mean, I can see making amendments as along the lines of what people have discussed here, and then I would just have a description of what, you know, that we incorporated these comments that were on. Okay.
Okay, I'll turn the floor over to the panel, and I'm actually requesting if anyone would want to make a motion.
Thomas Russell, I move we do not accept this conclusion.
Does anyone want to second that motion? Okay, so the second was Dr. Burton, just out of convenience, there was more. So all those in favor of accepting the motion to not accept the statement, please raise your hand. So that's 5-0 not to accept, okay? Did I pass the first one? Because we got like 27 more to go, so.
Yes, that was fine.
That was
Thank
fine,
you.
that was
And
fine,
I just
okay.
want to make sure, and we captured your reasons, and no one has anything addition that you want to add. Is that correct? Okay, great.
Okay. So the draft scientific interpretation, the second one, is that significant effects were not dose responsive. And again, I'm not going to try to read the whole thing here, but what I'd like to do is, again, I'd like to do a straw vote, an informal straw vote, to just see how many members of the panel would accept or not accept this particular interpretation. So those that would accept it, please raise your hand. So 4, and There's one dissent, and I think it's actually important for us to hear why not even in an informal straw vote. So Dr. Trinan, could you explain why you didn't raise your hand?
Well, what I struggle with some of these conclusions is what they don't say, I guess. And maybe this isn't appropriate, so I will avail myself of, some discussion about it. And, may change my mind. But one of the things, there's a statement that there was not a clear pattern of consistent responses in the stop dose and continuous dose study arms. On the surface, that's correct. They weren't the same. I guess my question is, why would you expect them to be? So I guess that's where I struggle, because I'm making a conclusion which has implications, but the statement itself, I think, is true. But I guess I don't know if that's necessarily something that has to be true, that they should necessarily be the same.
So the way I was interpreting this, and clarify for me, Barry, if I was misinterpreting, was within the stop dose and within the continuous arm, we didn't see any clear patterns. I mean, this is what Barry was talking about, where you'd see something in this dose for one response, this dose for another response, so within those different arms, that you didn't necessarily see clear dose response patterns, which we generally tend to look at in terms of dose continuum within, thinking of those as groups, as opposed to making those comparisons between stop and continuous, which as we point out, we weren't trying to really make too many of those. We were making qualitative comparisons. And clarify me if I missed your intent behind that, Barry. But if we go back to the figure 1, the heat map kind of, if you look in those, what we were looking at was there wasn't any. You saw in general lots more going on at the high dose. So that's what we were looking at here. That this didn't fit any kind of traditional clear dose response when you look at the continuous and when you look at the stop doses. Does that make sense?
Oh, sorry, and I can agree to that. I guess sometimes there are some comments in there, though. The stop dose group was almost used, it seems like, more for a comparison, the control, not statistically, but like intimating that it was potentially due to biological variation because of that. So I guess I was assuming it was between dose groups as within a stop dose group. So if it's just within discrete groups, I think this is a true statement, but I guess from some of the write-up in the report that I didn't think that was necessarily the intent of this. So
I fully agree with that. I had trouble interpreting, Janet too. I had trouble interpreting this as well, whether it meant within or between, using the word in. So I interpreted it eventually as within, but it was somewhat confusing.
And just to clarify, if you look at statement number 4, that's where we start to talk about between the arms. Animals in the stop and continuous were handled differently, that's where the issue of comparing, this is about dose response. I hope that clarifies the...
Okay, so based upon the informal discussion and straw vote, what I would ask is whether or not anyone on the panel would want to make a motion to accept this statement.
Tracy Bunton, I make a motion to accept.
Mike Connor, I second that.
Okay, so we've got a motion and a second. All those in favor of accepting this statement, please raise your hand. 5-0. Thank you. Okay, number 3, please. So, straw vote. All those in favor of accepting this statement, please raise your hand. So we have a couple of dissenters. So same process. No, I mean, using Dorman's rules, most of you have not watched me in action at the Board of Scientific Counselors and other meetings. I believe my colleagues at NTP can attest to the fact that I'm as big a pain in the ass as anyone they've ever encountered. Correct?
but we get the comments out.
So,
It's good. That's why
so,
you get comments out.
right, but so don't feel at all chagrined by the fact that you're making comments. I mean, I think that strengthens the whole peer review process. So for those individuals that were opposed, could we please have a few minutes discussion about what your concerns are with respect to this statement?
This is Kim Trinan. My concern is I think I'm unable to make the statement because I don't have a control group, unequivocally. I don't have a control group that doesn't have any estrogen or any type of BPA or other estrogenic compounds. And so I don't know. It's like trying to guess at something that there's no way of, I don't think there's any way of knowing. I think it's unlikely. But just to unequivocally say that there's absolutely no effect, I think is very difficult.
I think my concerns were with the very strong phrasing of did not affect the interpretation of the study. Although it did appear that the BPA levels from the diet were very minimal. I did have some reservations due to the potential contamination and the differences that were observed in the sensitivity analysis. And so because there were some significant differences in the sensitivity analysis that were not seen in the analysis of the full study, it's just really difficult for me to say that does not affect the interpretation because the interpretation is different. So it was a very strongly worded statement to me, but it was more so the unintended sources than the diet as well.
And just for clarification, because it's been a few minutes since we talked about the sensitivity analysis, that was with respect to the cohort 0, cohort 1 maybe, I can't remember which of the cohort 1, cohort 0 sensitivity analysis that was performed because of animals being cohabitating in the same room with the experimental groups that were going to be used with the academic, where there was a concern about potential cross-contamination, correct? So just to capture that. So go ahead.
Thomas Rosel. So I read this statement very literally, meaning that this did not affect the interpretation of the study. I don't read that the background exposures did not affect the response of the animals. I think this was clearly brought out in the study. We know what these levels are, and it's up to the reader to decide whether they think that may or may not have had an effect. I think that the report indicates that the report writers don't think it had an effect, but the levels are there. And people can make up their own interpretation. So I accept that the writers can have an interpretation of the data, and the readers can interpret it a different way. So I don't have a problem with this statement because I'm free to interpret it my own way. Because I don't interpret this statement is telling me that there was no effect from the background levels, because you don't know that for sure. So that's sort of how I look at it, and that's why I support it.
Anyone from NTP, NCTR would like to comment in any way?
I understand this logic. Yeah, and I think it's, at the end of the day, you're always trying to interpret relative to the control, and we in this case, because we could measure it, oftentimes you in a study you actually don't know what your background rate is because you never actually measure it. We measured it, and we know that, as Louisa pointed out, that the diet was at least tenfold lower. So that gives me confidence that I can interpret that there was actually an exposure differential between the 2.5 and the control. In contrast, if I had not actually measured it and someone says, well, you had background exposure from the feed, but you don't know what it was, and 2.5 we know is a very low, I would have a problem interpreting. And I think that's what you're saying, and that's, I agree.
Is that what you're saying? I thought, again, that you were reading it such that, this is Contranin, that the interpretation is there, and or that you can interpret it any way you want to, but that, so I didn't get that from what Thomas said. I thought, it seems to me that you're saying that that you know, or that you believe that there was no effect. And is that what you're saying?
Again, I don't think I would word these conclusions exactly the same way. So I understand what you're saying, because if the way I interpret this statement is that that we have the data did not affect the interpretation of the study. Well, it sort of did affect their interpretation. They have an interpretation, but it doesn't. Their interpretation doesn't stop me from having my own interpretation. The statements, both Dr. Trinan and Toz, the statements you made was you don't agree with this because you felt we can't decide whether the background levels had an effect or not, right? Because there was not a control group with 0 BPA. So that's what I hear, and I hear that concern. I actually don't think that's likely or possible or feasible. So I don't want to take away this conclusion because I don't think we could get there. It doesn't seem like a reasonable request. I guess is what I'm saying. But I agree. The wording it's not perfect.
So I'll ask the panel a question. Is the spirit of question 3 here, interpretation 3, one of confounding? And how do we want to give any advice to NTP, NCTR with respect to whether the low levels confounded the study, which is different even than interpretation? So I see no enthusiasm for that. So I will turn to the panel and ask whether or not there is someone who wants to make a motion to accept this phrase, and then a second, and then we'll vote on it. And I think we've given NTP, NCTR some guidance, and if we don't think we've captured all of the comments, we can do that. But I'll ask, is there a motion to accept this phrase?
I move to accept this as written.
So that was Dr. Connor who made the motion to accept the phrase. I'm in search of a second.
Thomas Rosel, second.
Okay, so Dr. Rosel seconded it. All those in favor of accepting it, please raise your hand. We have 3. And those opposed, please raise your hand. So we have 2. And Dr. Wolf, you're collecting names, right? And then I'll go back to, is there any, and you've collected the comments from the previous go-round of informal comments. And so does anyone who's voting no want to raise any additional points with respect to this phrase to give guidance to NTP, NCTR? Or if your previous comments capture it. Okay. I'd probably be the last one to ask that because we're doing Dorman rules of order or non-order, but go ahead.
Thomas Rosel, I'm just curious, like, what happens after this? So obviously we don't have unanimity, which is fine, right? Is that going to just be taken into account? based on our comments and the report and these conclusions, possibly revised to clarify things, or what happens with some these kind of votes?
All the comments that you've given us are absolutely going to be taken into consideration. The reason we ask for why someone does not support something and we ask for a vote is to get advice back to NTP, NCTR on where we should consider making revisions or providing additional information and so forth. So what we've heard is where there were lack of clarity in what some of the words mean. We've heard where you theoretically thought that words that were in an interpretation maybe weren't appropriate or you were interpreting them in a different way. So yes, this is all advisory back to us, and NTP, NCTR will take them into consideration and would likely make revisions to what they're considering or the wording of their interpretations, trying to understand how to make them clearer based on what they heard from you. So does that help?
Yes, that helps, and I think it reassures me that if we're not completely clear, it would be better to send a mixed vote or a negative vote than just blindly approving them.
And the other thing is the peer review comments will be written and be part of the report at the front matter of the final report. The peer review decisions, the discussion, a summary of that is included so people can see what the final conclusions were, what the actual peer review comments were made. The comments that the revisions actually then go to essentially the editors of the report, which are essentially these two guys sitting at the end of the table and Dr. Birnbaum, who have to accept or reject whether the revisions that we make to the report really met what the reviewer said. And if not, why not? And they would have to accept or reject those responses to those recommendations. That's how the peer review process works. And tell me if I got that wrong there, Mary.
No, that is correct, and that's a good point to make. So not only do we prepare the peer review report, which will certainly capture your reasons, the votes, and so forth, why, what the panel was trying to communicate to us as to why they had a difficulty with a conclusion or whether they thought a conclusion was absolutely appropriate or not. But at the same time, as Nigel said, ultimately, as the staff make revisions, there's a next step process that go to Dr. Berridge and Dr. Slicker, where they will hear what the staff said with regard to how they thought the final disposition of your comments should be, the revisions they propose to make to the report in response to them, and they'll accept them, or if they disagree with them, they'll ask the staff to go back and think a little more, or they'll say, yes, this is great. We think this appropriately addresses what we heard as advice to NTP. And all that will be on the web once it's finished.
Number 4. Okay, straw vote. All those in favor of accepting number 4, please raise your hand. Okay, no one has raised their hand, so that sounds interesting. So let's go on to opening it up to the panel for points as to why you have voted to not accept statement number 4.
So the reason I would vote not to, Mike Connor, sorry, excuse me. The reason I would vote not to accept number 4, although I understand where the spirit of the comment is, this comes under the previous discussions we've had about adding appropriate things to the weight of the evidence, and it's written kind of as a universal statement, and it doesn't necessarily apply to all the findings that you might want to have explanations for. So I think it is a bit too broad, although I understand the spirit of the comment, so I think not accepting this comment, again, will have no overall impact on the interpretation of the study. It just takes out this degree of specificity at this point, which seems to be being applied universally. So anyway, that's why I would vote no at this point.
Other comments from other panel members? And also, please keep in mind that in a lot of ways, this discussion oftentimes becomes the most, I'll say even some of the most critical things that NTP and CTR is going to hear from the panel. So just please keep that in mind. So if there are other comments that you want to raise, now would be a great time to do it.
Tracy Bunton. So it just seems like it's not necessary. I feel like it's almost taking a step too far that you don't need to take to put this in here. And I don't know if it's even valid. I mean, the statisticians can kind of address that, what I have here. Not sure if it's necessary or valid to make this comparison. So I just, I wouldn't agree with it.
This is Kim Trennan. It's interesting. I find that this statement is true, but what I find is, again, what it doesn't say. Is it necessarily valid to do that, or necessary? So that I agree with you, but when you look at the statement as it's stated, if you look at some of the controls across different arms, they are different. So that's where I struggle with this question. But again, it's kind of like why we need. I think what I struggle with is what kind of maybe what I think the intent is versus just the statement itself. I think is true, but the intent, I think, and the way it's presented again in the report is what I'm more concerned about.
Any response from NTP, NCTR?
Again, I understand. That is a true statement, I think. But I understand where you're coming from, and I think we can deal with it in the revision.
And I think, Nigel, one of the issues was to try and put into some kind of context, of what's occurring on one side versus the other, that it might have been statistically significant, but it sits right where, but we didn't actually compare those. And so it's kind of, again, trying to thread this needle between providing a biological context of this might be within the range of normal, but at the same time, not statistically comparing, which is inappropriate to go make those comparisons. So, and I think I appreciate the comment about it's too broad. Would it be better if we were a bit more specific of specific cases where we felt that was important for the biological interpretation?
Yeah, I think, sorry, Mike Connor again, has been done in other NTP reviews. Some of these at this level, the comments are very specific to a specific finding. And I think here where it's just so broad, although it's specific in one way, it's so broad, it seems to be so broadly applied that I don't think it adds value to put it here in terms of explaining the results or your interpretation of the results. That's the only reason I would take it off of here, because it doesn't, refer to any specific findings. So that having been said, it's not going to impact the report or our interpretation of the validity overall of your interpretations by voting no on this one, I would say. That's my feeling.
Thomas Rosal. Yeah, I don't think this belongs as a general conclusion. I think if you have a general conclusion about a result of the study, that's what you should put here. I actually think it sounds rather apologetic and opens the door for criticism when it doesn't need to be there.
Okay, so I'll turn to the panel to ask. Sure.
Janet, did you? Excuse me, did you give your reason?
I didn't give it.
Okay.
Okay.
I'm sorry. I agree with what's been said regarding it being too broad, and I think that was my main concern. And the other concern is just to make sure that the results would be presented with balance, to say in several cases, this occurred, but in other cases it did not. It's a little bit leading and just focusing on the cases where it was different and not the cases where it was not different, and not at all mentioning the ones that were there. But I actually just, in general, feel like it's not necessary.
Okay, so I'll turn back to the panel and request a motion and second for a motion to not accept statement number 4.
I move not to accept statement number 4.
So that was
Mike Connor.
Connor. And Dr. Tryon seconded. All those in favor of the motion not to accept statement number 4, please raise your hand. Okay, thank you. That was unanimous not to accept it. Number 5. So an informal straw vote, how many individuals on the panel would accept this statement? Please raise your hand. That's everyone. Guess we could move to a motion to accept it. So let's go to a motion to, can I get a motion to accept it?
Yes, I moved to accept it.
You moved to accept it. So that was Dr. Trinan and seconded by Dr. Burton. All those in favor say, raise your hand. 5-0 in favor.
I think the word may really helps.
You like May. Okay. Any comments at all that we do want to try to pass forward, or is that we're comfortable here without any additional comments? Okay, number 6. So straw vote. All those in favor of this comment, please raise your hand. Back to 5, all in favor. Once again, I'll request a motion to accept statement 6 then.
Thomas Rosso, I move to accept statement 6.
Okay.
Mike Connor, I second.
All those in favor of statement 6, raise your hand. 5-0. And again, any clarifying comments that we do want to throw out there at the last minute, just for completeness?
Janet Hughes, I agreed with the statement, but I didn't feel like it was particularly specific, and it might have been helpful to add some more details as to particularly what systems did show effects.
Mike Connor, the reason I didn't qualify it is because, again, I interpreted that group as showing sensitivity to the estrogenic effects, and so when we identify effects at that level, that it's validating the model sensitivity. It could have been more specific, but in fact, that group was designed to just test the sensitivity of this group or this particular study. So that's why I accepted it as written.
In case you're wondering, this leaves us 1 hour and 15 minutes from the schedule to discuss number 7. And so I'll do a straw vote. All those in favor of accepting statement number 7, please raise your hand. Okay, so I'll open the floor up to discussion by the panel as to why you would not accept statement number 7.
Mike Connor, the reason I wouldn't accept it just as written is that as we've gone through the whole discussion today, it sounds too dismissive because in fact there's biological variation, there's other weight of evidence argument that goes into interpreting any given finding as likely treatment related or not, and I think it by writing it and accepting it as is, it kind of dismisses all the other arguments that were brought up that you could support or detract from a given finding as treatment related. And so again, as Tom Russell said and one of the others, it sounds unduly apologetic. It's like defensive at the front when in fact there's for any given finding, as we've discussed, is likely to have a more robust argument coming up now in the revised version. And so just dismissing it all as biological variation sounded a little light on explanation.
Other comments, please?
I think I addressed my concerns earlier with biological variability, but I do think that the distinction that was made previously between biological plausibility versus biological variability is important. I would feel much more comfortable with discussions of plausibility of effects rather than variability because, I mean, obviously, if you have a very large study, things can be statistically significant when they're not clinically meaningful or biologically meaningful. But I'm not sure that that's really the case in this study. And even if I guess, and the point is just that the statistical methods do take into account the variation, and so I feel uncomfortable with saying, dismissing them in terms of biological variability. And I also think there could be more interpretation in the report in terms of biological plausibility and interpretation of the results.
Go ahead, Dr.
I would
Martin.
just agree that it's too broad and now at this point a bit too dismissive, trying too hard to fit everything into biological variation. So, and I think that's not necessary for this report.
So it's probably useful for everyone who's leaning no to provide guidance here. So we'll just go around the table. So Dr. Trine.
Yeah, Kim Trinan. I guess I also struggled. There is one statistical, the infamous, adenocarcinomas that are outside of the variability. So I think, on that statement alone, it is only one finding, but I think it's very broad and it's not necessarily true for every single finding.
So, go ahead, Tom.
Thomas Rosel, I think the statement is too all-encompassing for a general conclusion. I agree with using variability as a specific argument for specific data sets. That's fine with me. I remember one of the data sets, there was an incidence in the controls that were much higher than the incidence in the historical control group. So I do think some of these data were extremely variable and would affect my conclusion for that specific data. So, but I just wouldn't put it as a general conclusion. I think it should be one piece of an interpretation of specific data sets.
So, yeah, Mike Connor, you're asking for guidance, and I think the guidance I would give is pretty much reflects what Tom and Tracy had said earlier in some of her comments, is looking at all the things you would put together for biological plausibility, including what's happening with other organs. If this is biologically meaningful, what's happening in the other organs you would expect to be affected, and some of the points that I brought up earlier about building the argument for or against biological plausibility. And so I think, again, is kind of reiterating what I said before, the guidance is removing this statement as a broad statement would actually strengthen the report and focusing on each finding with all the data available. And in some cases, this probably does contribute to it, but not universally as strong as it's stated here.
So anyone from the other?
So just as a point of process, Mary, so ultimately as a reviewer, do I have any prerogative to ask some clarifying questions of the panel? Step out of line my first time here.
No, you can certainly ask clarifying questions, but
So if I ask an inappropriate question, you just tell me that one's not appropriate.
no, but we still need to finish this particular one.
Well,
You can go ahead and ask what you would like.
Well, what I'm asking might have some impact on where this goes. That's why I'm doing it now. So I've already confessed that I'm coming into this pretty cold because I'm coming late to the party, right? And so, I'm also coming from a place that's not this stuff, right? So I come from the pharma side. So there's some very fundamental questions that are bouncing around in my head. One is BPA bioactive? Is BPA, if it is in fact bioactive, is it an endocrine active agent? What is that activity? what doses are that activity occurring, and are they adverse, right? Which I expect those are the things that are bouncing around everybody's head. So what I'm trying to understand is in this study, are any of those questions being answered? I mean, does this panel believe that this study demonstrates that in fact there is bioactivity? Does the panel believe that that the bioactivity includes some endocrine activity, but lacks specificity about exactly what that is because of the variability in the data? Does that make sense? And does anybody have any clarity on that about what this study is or is not doing in the context of those very simple?
I think that might be best answered by the colleagues at NTP and NCTR, but as I look at the data set and what the purpose of this study was, which is to design a study that allows some of those questions to be answered, but not necessarily all those answers are going to be within the context of this study. That's where some of the academic collaborations come in. So I think with the limitations of using the traditional approaches to looking at for biological effects, that is morphology, clinical pathology, body weights, and so forth, and there's a little additional biology here, looking at vaginal opening dates and cycling. In the context of that, I think the study answers a more limited question and not perhaps the broader questions you asked, which is because there may be hormonally things going on that are going to be picked up in these other studies, which may be potentially important. But if you're asking, did it have morphologic effects on animals in this study and so forth and so on, except for the highest dose of BPA, possibly not, is the answer. But that doesn't answer your broader question about, is it hormonally active, and are there other things that could be detected as biological responses to this? Using the morphologic endpoints and the endpoints that were chosen for the study, not a lot except at the highest dose, I would say.
So that's sort of getting at one of the aims, which was to understand whether a typical guideline study allows you to have that clarity. And you're suggesting that without some of that other evidence, maybe that clarity is just not there in the context of this study and its design.
It contributes to the clarity, but I think one of the challenges is that there's been expectations, and you've probably seen them in the press, that this was the be-all and the end-all, and how do you possibly reach all these conclusions that actually haven't been reached by this study? This study is designed, the conclusions of this study are limited to what was measured, and I think that's, the ancillary studies are going to answer broader questions.
So I will ask the panel if there's someone who's willing to make a motion to not accept statement number 7. And also second it, a seconder.
I'll make a motion.
So that was Dr. Tooze. Who's going to second it?
Janet Tooze.
Right.
To not accept.
To not accept.
Mike Connor, I second that motion.
All those in favor of the motion not to accept statement number 7, please raise your hand. Is there any additional clarifying comments that weren't raised earlier that any of the panel members would like to raise at this time with respect to number 7? Okay, thank you. So according to the agenda, I get to introduce Dr. Berridge to make any closing remarks, but before I do that, I would like to make a closing remark on behalf of myself as chair today. I really appreciate everyone's presentations, and I appreciate the efforts of the panel in putting together the peer review comments. I enjoyed meeting all of you and hope that today's process was informative for our colleagues at NTP and NCTR. And with that, I'll turn it over to Brian.
So on behalf of the FDA, I would like to thank all the members of the panel for accepting this exercise and for your participation. Thank you.
Thanks, Gonzalo. So first off, thanks to David for running a well-oiled machine of a peer review. So I really appreciate that. Huge kudos to everyone at NCTR and NTP who contributed to the study. As everyone has recognized, it was incredibly complex and it was a well-executed study. So that's been fantastic. And thank you to Mary and her associates and all the efforts to put this thing together. So I think it's played out really, really well. Again, thanking the peer reviewers for your level of engagement, the time that you spent thinking through this, the challenges. Again, as I said at the front part of this stuff's hard, right? That's why not everybody's doing this. It's difficult, and so your perspectives, your experiences, your challenges are all really, really good. And as Mary has noted, all of those things will be taken very seriously, incorporated into any considerations for revisions to the report. So thank you for that. And thank you also to everyone else who attended and has participated in the study.
So I get the last for logistics. But yes, let me thank you very, very much for being a great panel, for meeting deadlines that we, ask of you when I know you have other jobs besides just helping us out, but you provide a great service to NTP, and we're very appreciative. As I mentioned, you will probably in a couple of weeks see the draft peer review report for you to review and make sure that we appropriately captured your comments. And once we have that, it will go to the chair for final sign-off. It will go in on the web, and as Nigel mentioned, it'll be incorporated into the final report. So again, thank you very much. And it was, to hear the no reasons is extremely, extremely valuable, because to say just yes, okay, we think everything's wonderful, but what we heard when we heard some of the no's, that there was differences into how you looked at the statements yourselves, and so that was very, very insightful information for you, and I appreciate that. And I believe we have all travel for everyone to take you to the airport or back to the hotel if that's where you're going. Thank you.
Okay. Thanks again. Safe travels. And I get to use this again. We're adjourned.